And now it's my pleasure to introduce Dr. Larivière from the Brigham and Women's Hospital and University of Sherbrooke, talking about cortical atrophy, pre and post-surgery in TLE.
All right. Thank you very much, Boris Bernard and Sophie Valk, for the invitation to speak. It's always a great pleasure to be here at OHBM. And as you already know from Luis Concha's great keynote speaker yesterday, and also from Ke's earlier talk today, temporal lobe epilepsy, or TLE, is one of the most common drug-resistant epilepsies in adults, and it affects about 1% of the world's population. But despite appropriate medical treatment, about 1/3 of patients continue to suffer from intractable seizures, in which cases resective surgery is often considered to be the best treatment option to arrest the seizures. And this is usually done by resecting primarily the hippocampus, but oftentimes also by resecting nearby mesotemporal lobe and temporal regions. And TLE is actually quite interesting because one of its most frequent pathological and imaging findings is hippocampal atrophy, which is usually secondary to hippocampal sclerosis, but that is also has been found to be quite variable across patients. And the interesting thing is that when we zoom out of the hippocampus and we look at the brain as a whole, it's been very well documented by both cross-sectional and longitudinal imaging studies that TLE is often associated with thickness changes, especially cortical atrophy in regions that are well beyond the affected hippocampus, often reaching bilateral frontocentral cortices. So the question that was very interesting in my postdoc then was, what's the relationship between hippocampal atrophy and atrophy in distant regions in the cortex? So to answer this question, we turned to neuroimaging, and we quantified hippocampal atrophy in patients with TLE, and we used these areas of hippocampal atrophy as seed regions in a seed-based functional connectivity analysis, and by doing that, we obtained brain networks that were either negatively connected to areas of hippocampal atrophy, so the network in blue here, or regions that were positively connected with areas of hippocampal atrophy, so the network in red. And interestingly, we found that cortical abnormalities, which Louis described very well yesterday, actually localized to these two hippocampal networks, whereby we have white matter changes that align very well with the red positively connected network, and cortical atrophy that overline with the negatively connected blue network. So this blue negative network not only encompasses cortical atrophy patterns, but we also found that functional connectivity of responsive neurostimulation electrodes, or RNS, which is a device that's implanted in the brain to respond and detect seizure activity and responds to it by stimulating, for instance, in this case, the hippocampus. So functional connectivity analysis from these electrodes to that blue network was associated with therapeutic benefits. So while we expected to see white matter abnormalities aligning with the positive network, it was actually quite surprising to see cortical atrophy aligning with the blue negative network. And this doesn't really fit with the known transneuronal spread model that was pushed forward by initially Bill Seeley and colleagues, where usually in that model, cortical atrophy spreads to the rest of the brain via the positive network connections. But in our research, at least in TLE, we show that atrophy preferentially hits the negative network. And so this might mean that cortical atrophy happens in a brain network that is trying to compensate for seizures, and as opposed to being a consequence of the seizures. So the follow-up question we asked them was, well, is this negative network also important when the hippocampus is surgically resected in TLE? And is it specifically in any way clinically relevant? So to answer that question, we were really fortunate to obtain data from 91 patients with both preoperative and postoperative MRI, as well as longitudinal data from 6 to 8 age, sex, and interscan interval matched controls. And these patients specifically underwent either laser ablation or surgical resection as a treatment of their seizures, with no difference found between surgery type and surgical outcome, so whether they were seizure-free or not after surgery. But we did find that larger surgical resection volumes, as well as greater ipsilateral hippocampal volumes, or greater hippocampal atrophy before surgery, seemed to have a better post-surgical outcomes, which are two important known factors to keep in mind in our analyses. So then the first thing we did was to segment the surgical cavities in each patient using their post-operative MRIs. And we did as we did before with hippocampal atrophy. So we used these cavities as seed regions in a functional connectivity analysis to compute lesion networks. So with the resulting maps showing functional connectivity between the resection site and the rest of the brain. And despite heterogeneity in lesion location and extent, all of them seem to be, once again, positively connected to the red network, the default mode network, and negatively connected to frontal parietal cortices. And then we looked at group-level longitudinal changes in cortical thickness. And when we compared patients with TLE to controls, we found that TLE patients had greater cortical thinning in areas near the resection site right after surgery, but also quite a fair amount of cortical thickening that was especially found in bilateral frontoparietal cortices. And we can see from the graph below, actually, that the majority of patients do, in fact, show thicker cortex in these red outlined regions after surgery relative to before surgery, which is not something that we observed in controls. And then to see how these regions that show a pre to post-op change in thickness relate to the two lesion brain networks that that are functionally connected to the area that was surgically resected, we simply overlapped the significant clusters onto each network, and we can see here that the thinning near the resection site aligns well with the positively connected red network, whereas cortical thinning better aligns with the blue network. So this was quite nice, but we also wanted to see whether this relationship was reproducible across patients. So we went back to our approach and generated patient-specific thickness change map showing the strongest cortical thinning regions as well as the strongest cortical thickening regions across every individual. And from the overlap map at the bottom, we can see a rather homogeneous pattern of cortical thinning in the temporal lobes, but also a quite rather heterogeneous pattern of cortical thickening with peak overlaps in bilateral frontal central parietal regions. And then using these patient-specific thickness change maps, we looked at how much thinning and thickening there was in each of a given patient's lesion network. So in this example patient here, for instance, we can clearly see that most of the cortical thinning after surgery aligns with the red network, so the network that's positively connected to the site that was resected, whereas cortical thickening seemed to be preferentially overlapped with the negatively connected blue network. And when we compute these overlaps across every patient, we can see that most patients show significantly greater pre-op to post-op thinning in the red network, as well as significantly greater pre to post-op thickening in the blue network. And we further split these associations according to ipsilesional versus contralesional hemispheres. And we see that most of the thinning actually occurs in the ipsilesional hemisphere, so in areas near the resection site, possibly, whereas stronger thickening effects were actually observed quite far from the resection site into the contralesional hemisphere. And finally, in looking at how these associations might be clinically relevant, we found that, as far as we can tell, that pre to post-op cortical thinning in the red network had not much to do with surgical therapy, and that every patient showed thinning in that network regardless of whether the surgery was successful or not. But more interestingly, we found that those patients who did become seizure-free after surgery tended to have more cortical thickening in the negatively connected blue network relative to those who continued to have seizures after surgery. And this association remained quite significant after controlling for surgical cavity volume as well as ipsilateral hippocampal volume. So in summary, the main takeaway here from my talk really is that the negatively connected brain network appears to be quite clinically relevant in TLE, and it might hold important and valuable information, but there's still a lot more work to do to fully understand and validate its significance. So last thing I want to mention quickly is that if you're into neuroimaging of epilepsy, I strongly encourage you to check out the Neuroimaging of Epilepsy Worldwide website and community, and subscribe as a member. It's not only is it free, but it'll also make you eligible to apply for travel awards to go to AS this year. And I also want to highlight all the beautiful tools that are open source and that have made this work actually possible, all the way from pre-processing of data to visualization and pipeline integration. And finally, I want to thank everybody who's contributed to this project and made it really, really exciting, especially my postdoc supervisor, Michael Fox, and as well as my collaborators and friends from all around the world. And finally, thank you for your attention.
Terrific talk, Sarah. Thank you very much. There was already one question in the poll asking about the software, so you already highlighted those.
Yeah. Maybe I can go back.
Mary Pat, please.
Thank you very much. Beautiful talk, Sarah. Thank you.
you.
I might have missed this, but did you see any difference in the thickening from the patients who had laser surgery versus ablation surgery?
I haven't looked at that, but I think a stratification analysis could be quite nice also. Yeah.
What's your hypothesis?
Yeah. I'm not sure it actually relates that much to the type of surgery they have, but perhaps more about the amount of atrophy they have before surgery.
Okay.
That would be my guess, yeah.
Okay, fair. Thank you.
Hi, Davide Gianpiccolo, Queen Square, London. Great talk.
Thank you.
I just wanted to ask you, so when we speak about epileptogenic networks, we always speak about what makes the patient seize. I was wondering, you haven't talked about it, but of course, since our patients are not seizing every time, there are mechanisms that stops them from seizing. Do you think there might be a relationship between this negative network that you find, a system that stops seizing in our patients? And if yes, would you like to elaborate a bit on this?
Yeah, absolutely. I think one of the hypotheses we came up with was that atrophy in that negative network might actually be a good thing. And it's maybe just a response of this network trying to activate itself to deactivate the other red network that is seizing. And after surgery, for those patients who become surgery-free, there's not a need for this network to hyperactivate anymore. So maybe it has time to grow back or to regain some function somehow. But these are, we don't really have all the data to show this, but this is our kind of working theory.
Thank you.
Hi, really great talk. I was wondering, do you have a biological explanation as of why you observe cortical thickening after surgery?
The thickening, yeah. Once again, it's all what I'm thinking in my head, but I'm thinking it might relate to dendritic sprouting after surgery, and this would be in line with a regain of cognitive functions. Also, we don't have all the data for this, but the next steps would be to look at some diffusion models and metrics to show if there is something that points to that direction of dendritic sprouting in these regions that are thicker after surgery.
Okay, thank you.
Yeah.
So please join me in thanking Sarah and all the other fantastic speakers. Thank you everyone for coming. I think if you have further questions, you can also just chat with the speakers who are still here in the room.